I'm Bill McIntyre from Hamilton, Canada, where I work at McMaster University and the Population Health Research Institute. And today I'm going to be talking about the ARTESiA substudy results that we're presenting here at EHRA 2024, looking at the impact of device-detected atrial fibrillation episode duration and frequency. So this is a substudy of the ARTESiA trial, and if we look at the main ARTESiA results that were presented at the American Heart Association in November 2023, what that showed us is that for patients who have device-detected atrial fibrillation, apixaban, as compared to aspirin, reduced the risk of the primary outcome of stroke or systemic embolism. Now, not surprisingly, it did also increase the rate of major bleeding, and if you look overall, the absolute baseline risk of stroke is around 1%. When we have a therapy that's effective like this, it behooves us to look into the subgroups of patients that might benefit more or less from the intervention, and that was exactly the goal of this study. As soon after the results of ARTESiA were presented, the two real groups that people wondered about is based on CHA2DS2-VASc score and episode duration. And if we look at clinical practice guidelines right now, whether you look at the American or the ESC guidelines, both of them really have a table that says the higher your CHA2DS2-VASc score, the longer your episode durations, the more likely the patient is to benefit from oral anticoagulation. So we aim to look specifically at episode duration and frequency within ARTESiA. So this is a substudy of the ARTESiA trial. So the ARTESiA trial was around 4,000 patients, and it was a randomized trial of apixaban versus aspirin. And the patient population is patients with device-detected subclinical atrial fibrillation picked up by a pacemaker, an ICD, or an implantable monitor. Now in ARTESiA, patients had to have episode durations between 6 minutes to 24 hours of subclinical atrial fibrillation to be enrolled in the trial, and then they were followed for the primary outcome, which was a composite of stroke or systemic embolism. Now it's important to note that we followed patients in ARTESiA and we did update their episode durations. If during the trial follow-up the patient developed clinical AFib, which was detected on a 12-lead EKG, or episodes of over 24 hours, they effectively came out of the trial and onto open-label oral anticoagulation. So what we did for this study is we looked and we took a snapshot of what their atrial fibrillation profile looked at baseline enrollment, and for us that was actually defined as the 6 months prior to entry in the trial. And what we did was we classified patients according to the frequency of their episodes in categories of 0, meaning they didn't have anything in the prior 6 months, but something in the more remote past, 1 to 5 episodes, or 6 or more, and we also classified them according to the duration of their episodes between 6 minutes and 24 hours. We looked both at the association of these factors with your absolute risk of stroke, and we looked at the interaction to see if these factors would actually impact the treatment benefit for apixaban for stroke reduction. So let's first talk about episode duration. So what we did is we binned patients into roughly equal categories based on their episode durations, between 6 minutes and 1 hour, between 1 hour and 6 hours, and between 6 hours and 24 hours. We found that for each of these three groups, the absolute risk of stroke was actually quite consistent, clustering in around 1% per year. So we really did not see an association between the longest duration of subclinical atrial fibrillation and stroke, and this held up when it was adjusted for the treatment allocation, apixaban or aspirin, and adjusted for the CHA2DS2-VASc score. When we look at that same factor and its impact on the treatment effect, right, the degree to which apixaban effectuated stroke reduction, again, we did not see any statistical evidence of any difference, meaning that really episode duration didn't seem to matter. When we go over and look at frequency in our exploratory analyses, there was actually one really interesting finding. Around 18% of patients in the ARTESiA trial actually didn't have any subclinical atrial fibrillation in the 6 months immediately prior to enrollment. They had it in the remote past, and that was the basis on which they qualified for the trial. This group really stuck out because their absolute risk of stroke was only around 0.5 or 0.5% per year. And when we compared that formally to patients who did have episodes in the 6 months immediately prior, we found that there was way lower risk. Okay, the risk comes out at about half. When we look at the actual frequency for people who did have episodes, so comparing groups with 1 to 5 episodes in the last 6 months with those with 6 or more, we didn't actually see any evidence of a difference either in the absolute risk or in the treatment effect with apixaban. Guidelines really right now are telling you to take subclinical atrial fibrillation duration into consideration. And a lot of that is based on the literature for clinical AF detected by surface ECG. We've seen pretty consistently in that literature that there's a relationship between episode duration or burden commonly being defined as percent time in atrial fibrillation, with risk and with outcomes. If you actually look back at the subclinical atrial fibrillation literature, we think that this actually really fits. We did an analysis of the classic ASSERT trial, which the primary ASSERT trial was published in 2012, and it actually found that between 6 minutes and 24 hours, there was no incremental jump in your absolute risk of stroke, but it was once you hit 24-hour episodes that your risk of stroke jumped. And that's really consistent with what we found in the ARTESiA trial. There's also a very nice meta-analysis by Sagres et al. That was published in the Journal of the American Heart Association. And what they did is they lined up the risk of stroke according to the duration of atrial fibrillation, and they did some meta-regression with a log-rank statistic, and basically they found that up to that 24-hour point as well, there's really no inflection in the risk. So what we're finding here in the ARTESiA trial, I think really fits specifically with the device-detected subclinical atrial fibrillation literature. We took a snapshot at baseline, which we think really reflects clinical decision making, to say, hey, there's a patient in front of me, what did the last 6 months look like for them? We really want to know if these hold up over the follow-up, the remaining duration of the trial, so that's something that we're working on. And of course, the other really big piece there is the CHA2DS2-VASc score. So people who are interested in that can keep an eye out for Heart Rhythm meeting in May of 2024, where Jeff Healy will actually present the results for how risk parses out based on different levels of the CHA2DS2-VASc score. So the key take-home message would, you have a patient in front of you that's had subclinical atrial fibrillation lasting between 6 minutes and 24 hours in terms of their longest episode in the last 6 months. It's basically all the same in terms of risk. We shouldn't be really worrying, was it an hour, was it 6 hours, was it 12 hours? These all appear to have the same impact on a patient's risk of stroke, and really no impact on the treatment benefit with apixaban. So we really don't think that that is a parameter that we should be using to risk stratify the patients. We can really simply rely on the presence of the arrhythmia as a risk marker, and then sit down and have an informed discussion about the risks and benefits of apixaban for stroke prevention for the patient.